So the next talk is on gastro-pancreatic neuroendocrine tumors. So this is kind of connected to what we heard from my previous talk. I need to acknowledge some of my colleagues from surgery and pathology. These three are from surgery, and then Mari Mino is a pathologist, because these individuals have taught me a lot. I have learned to appreciate the challenges they deal with in diagnosing and managing some of these neuroendocrine tumors, and I've also learned to appreciate the role of imaging in managing these patients. Now, when we look at the gastro-pancreatic neuroendocrine tumor, we know that although the number is low, the incidence is rising. You know, it is anywhere from 1 to 5% of all the gastrointestinal and pancreatic neoplasm. Majority, as we know, if you take distribution of all tumors, ileum and appendix is about 50% of neuroendocrine tumors because of the carcinoid that we talked about earlier. Pancreas is about 7%. Rectum is about 11 to 27%, and stomach is about 6%. So when we look at the incidence, GI tract has more neuroendocrine tumor, but when we think about neuroendocrine tumor, pancreas is the number one that comes in our mind, because the tumors that affect pancreas tend to be more aggressive, and also management can be challenging. So what we know about neuroendocrine tumors in the pancreas, that they constitute about 3 to 5% of pancreatic neoplasms. Majority are sporadic. That means we don't know who will get it, but now we also have identified certain genes, like in MEN and VHL patients. These patients are at high risk for developing neuroendocrine tumor, anywhere from 10 to 30% in MEN, about 15% in VHL. Now, surgical resection is the only curative treatment available, but it is high risk. For example, distal pancreatectomy can have leak in more than 40% of cases. So there is pretty high morbidity. Therefore, it is important for us to recognize if every patient will benefit from surgery. Now, what is also interesting from this graph, what you notice is, way back in 80s, the neuroendocrine tumors will present with symptoms due to increased hormonal secretions. But in the recent past, we have noticed that vast majority of neuroendocrine tumors actually are non-functioning tumors. And significant number of these tumors are detected incidentally on images, both cross-sectional images at endoscopy that is performed for other indication, and we detect these lesions. So it's a big challenge, and it is growing over time. And if you look at these 168 resected pancreatic neuroendocrine tumors from MGH, you notice that about 60% are non-functioning, and about 40% are functioning. Of that, insulinoma is about 30%. So if you think about non-functioning, and insulinoma is close to 80% to 90% of the tumors. And then others are gastrinoma, glucagonoma, and some other rare neuroendocrine tumors of the pancreas. And when you look at the distribution, body and tail constitute about 60% of tumors, and a third of tumors are in the proximal part of the pancreas. Now, what is important to understand is the pathology, the classification of neuroendocrine tumors has been revised few times. And in 2010, a WHO classification has been proposed, and that factors following thing. It looks into the grade, it looks at the mitotic count and Ki index. And based on these factors, if the grade is low and the mitotic count is less than 2 per 10 high power field, and Ki index is less than 3, these tend to be well-differentiated tumors. So classically, carcinoid tumor will fall in this category. And as the grade increases or the size increases, all the biology of tumor increases, the prognosis changes. So unlike other tumors where we have benign and malignant, neuroendocrine tumor has this diversity, and which is based on various factors. Now, when you look at the distribution of neuroendocrine tumor, we notice that non-functioning are about 60%, and majority of non-functioning tumor are pre-malignant or malignant. Therefore, in majority of cases, they are resected, whereas insulinoma, which is about third, only 10 to 15% are malignant, and rest all the neuroendocrine tumors are malignant. So one way to interpret this data is, except insulinoma, every other neuroendocrine tumor is likely to be malignant. So if we can diagnose insulinoma, those are managed differently versus the rest of the neuroendocrine tumor because risk of metastasis is much higher. So let me share with you our clinical experience from MGH. This is patients from between 1998 to 2014, all adults who presented with pancreatic neuroendocrine tumor. In 53 patients, we did not operate. We monitored them. And majority others, that 235 patients were resected. So let's look at the data. It is clear that over 10 years survival, if you look at those who are operated versus non-operated, operative patients clearly have benefit. So it supports the hypothesis that as much as possible, we need to operate patients once you diagnose neuroendocrine tumor. Now, the conundrum is, does the operative benefit extend to all incidentally detected neuroendocrine tumor? Because as I told you, majority of neuroendocrine tumors are incidentally detected. In our practice, 88% of non-functioning tumors are actually incidentally detected on imaging. So conundrum is, do we need to operate each and every of these patients? And it turns out size is very important determinant. Lesions under 2 centimeters in size, those patients who, if resected, don't have as much benefit of outcome in comparison to the lesions which are greater than 2 centimeters in size. Now, that information is important because if we detect neuroendocrine tumor in an 80-year-old, incidentally, a 2 centimeter lesion, it doesn't make sense to resect those patients. Now, the conundrum is, what happens to younger patient? If a 60-year-old, if we detect a small lesion, can we leave them alone? And my analogy to that is, I'm a dog lover, and I understand problems of life through dogs. Now, small dogs in general they are cute and friendly, but not all the small dogs. Like Annie is very friendly, but Chip, who is my dog, is ferocious. He's not friendly at all. So, so small doesn't mean benign. Let's look at this case. We have a 2 centimeter lesion in the tail of pancreas. It was incidentally detected, and this patient develops metastasis over time, as you can see here, right there. It develops metastasis. So size alone cannot suggest the biology of the tumor. Now, also what we know is there has been a lot of changes in management of neuroendocrine tumor. There are new drugs available. Because these patients live much longer than pancreatic ductal adenocarcinoma, there are more aggressive approaches like targeted therapy, intra-arterial therapy, anti-angiogenic therapies. All these are being applied in either independently or in combination to get the best for these patients. Now, with all these changes that are happening with treatment, the expectations from our clinical colleagues is also changing. They expect more from us. They want us to not only detect, but also characterize. See, one simple approach is you will say, once I detect a solid lesion in the pancreas, I know the risk of malignancy is very high. Why do I need to characterize? I can just say that it's a solid lesion, you take it out. But that is not true, as I told you earlier. We need to recognize mimics, the ones which look like tumor, but actually they are not. We need to try and understand tumor biology, especially when they want to do a more conservative management, staging, and also monitoring response to therapy. Now, CT is the modality of choice to assess pancreatic neuroendocrine tumor, and as we heard from previous presentation on small bowel, arterial phase imaging is desired. We need to get arterial and venous phase imaging because a lot of these functioning neuroendocrine tumors tend to be smaller and arterially enhancing. As you can see here, there is a small tumor here in the head of the pancreas. It's very difficult to appreciate that in the portal venous phase. This is a small tumor that was missed, as I mentioned earlier. This is a hypervascular gastrinoma metastasis in the lymph node that one can appreciate in the arterial phase. And when liver metastases are present, that are also arterially enhancing. Now, non-functioning tumor, on the other hand, which are majority, tend to be larger, greater than 3 centimeters in size, and they tend to show more necrosis and degeneration and calcification. And some of them also appear cystic, like as you can see, in these cases, they appear predominantly cystic with some solid area. So as they increase in size, a lot of cystic degeneration can happen. Now, one thing you need to recognize is you don't confuse these with cystic neoplasm of the pancreas. The way you recognize is there is no septations inside. You see a big lesion with solid component in the periphery, which gives a hint towards a solid mass which has undergone cystic degeneration over a primary cystic neoplasm of the pancreas. Now, how do we recognize malignancy or aggressive behavior? Now, on images, what we have noticed is a solid lesion greater than 3 centimeter has much higher risk for malignancy. Complex morphology, like solid and cystic component, increases risk for malignancy. Also, calcification is predictor of malignancy. And of course, if there are more obvious features like invasion, metastasis, pancreatic duct dilatation, or gland atrophy, the indirect signs, these also predict aggressive biology. So what you have to remember is size greater than 3 centimeter, calcium, and complex morphology. Those 3 things on CT or MR favors aggressive biology. Now, how good is CT in detecting pancreatic neuroendocrine tumor? It comes down to size of the lesion. For non-functioning tumor, which are greater than 3 centimeters, CT is almost 100% accurate. In functioning tumors, which tend to be smaller, CT is anywhere between 75 to 89% sensitive in detecting those lesions, because some lesions, especially insulinomas, can be less than 1 centimeter size. And for these cases, we do endoscopic ultrasonography for detection. Now, on MRI, which is a great modality for pancreas, one needs to recognize is that conventional teaching was neuroendocrine tumors are T2 bright. That is true only for 30% of cases, and also for functioning tumors. Non-functioning tumors tend to have very heterogeneous signal and variable signal intensity, but all of them show a good enhancement with contrast media. Now, this is the classic appearance that we have learned in the past is arterial phase enhancement and T2 bright. T2 bright is seen only in 30%, just keep that in mind. One of the benefits of MR is because you have multiple sequences available, you can leverage on those sequences to detect small isodense neuroendocrine tumors which are difficult to detect on CT. Like here in this case, with a strong clinical suspicion of a functioning neuroendocrine tumor, CT we did not appreciate. On T1 fat-SAT sequence, you can see a small dark lesion. Similarly, metastasis, when they are small, one appreciates better on MR than it is possible on CT, and when the lesion is big like this, it is not difficult on CT or MR. So here you can see T1 dark and arterially enhancing lesion. And MR in general has been shown to have better sensitivity and specificity over CT in the ranges of 78 to 100%. Now, how do you approach MR? I personally feel there is no single good sequence for pancreas. I take a look at everything. First thing I start with is look at MRCP because I want to look at pancreatic duct. And pancreatic duct can point to a problem. Here you notice pancreatic duct is prominent and suddenly there is change in caliber. Then I want to target in that area. I want to look at T1 fat-SAT, and here you notice there is a dark lesion. On contrast enhanced images, we can see the lesion. So MRCP can be a good way to start with, but look at everything. You are looking for basically mass effect, contour change, any atrophy, or change in ductal caliber. And then there is one type of pancreatic neuroendocrine tumor. These are called somatostatin producing tumor or a carcinoid equivalent in pancreatic duct. The way you recognize is these tumors tend to cause disproportionate ductal dilatation, and the size of tumor is very small. As you can see here, there is a gross dilatation of the pancreatic duct, and right at the transition, a small hypervascular lesion is there. Now, this feature has not been described in any other pancreatic neoplasm, and it has been shown to be specific to serotonin-producing tumor. So if you suspect, if you see a gross pancreatic duct dilatation, and at the transition there is a small lesion, suspect a serotonin-producing tumor. Those tumors tend to have better biology. They don't metastasize as much, and after resection, there is generally a good outcome. So again, just to emphasize on how do I look at MR, I look at MRCP, look at the pancreatic duct at the site, there is change in caliber, look at the T2, again, the duct stops there, maybe there is a lesion, I'm not sure. On T1 fat-SAT, I clearly don't see a lesion, maybe there is some heterogeneity. In the arterial phase, there is low density areas. In the delayed phase, I don't appreciate it very well. And then when I look at diffusion weighted sequence, I see that lesion very well. And it turns out lesions that are isodense to pancreatic parenchyma are not hypervascular. Diffusion is a great way. It's very complementary to recognize the lesion and go back and look at your arterial and venous phases images. So that's one great way to look at the diffusion in ADC, but also to assess biology. Generally, tumors which show restriction of ADC tend to be more aggressive than other tumor type. Now, other thing to remember on MR is you look at every sequence, and this case emphasizes that problem. Now, this patient, we were not suspecting a problem. This is CT scan. We did not see an issue. On a T2 weighted sequence, there was little heterogeneity in the tail if you compare to rest of the pancreas. On the T1 fat set pre, there is no abnormality. On the arterial phase, there is no abnormality. On the delayed phase, there is no abnormality. So there is no one sequence you can look at. But the T2, if you compare this pancreas versus this, there is more fullness and subtle signal abnormality. But we missed this problem. And few years later, this patient presents with that invasive neuroendocrine tumor with liver metastasis. So when you're looking at MR for pancreas, look at everything because there is no magic bullet. Other area where MR is very important is differentiating mimics with lesion which can be managed conservatively, which mimics like neuroendocrine tumor. And one such lesion is intrapancreatic spleniole. And they can be arterially enhancing, but when you look on MR, the signal properties of spleniole matches that of spleen. So here you notice on T1 weighted sequence, it matches spleen. On diffusion, it matches spleen. On enhancement, it matches spleen. So it is very easy, and it shows no heterogeneity to characterize that. Another lesion that can mimic neuroendocrine tumor is small serous tumors or microcystic neoplasm. They can arterially enhance, and we know that microcystic neoplasm can be managed conservatively. They need not require resections if we can diagnose them appropriately. Here you notice in the arterial phase, part of the lesion is enhancing, but on T2 weighted sequence, you can see the lesion is very bright with a central scar. In comparison, this is a neuroendocrine tumor with cystic degeneration. It is not as bright, it doesn't have a central scar, and on enhancement characteristics are very different, and it has a capsule in comparison to a lobulated outline of a serous cystadenoma. So that morphology on T2 weighted images and the enhancement pattern supports the serous cystadenoma diagnosis. And final word is screening. We are now in our practice in high-risk patient population, we are doing screening. And for MEN syndrome, where we know that 30% can develop neuroendocrine tumors, we start screening after 15 years of age with MRI in younger age group and CT in older for the chest, but MRI for the liver. And for VHL, we start screening from the childhood, and we use ultrasonography first and MRI if there is any abnormality detected on ultrasonography, and we do this 1 to 2 years. So in summary, neuroendocrine tumors are a very diverse group of neoplasm. Majority are arterially enhancing, and they can have a spectrum with differences related to their functional status. CT is the modality of choice and we need to get a good technique, the arterial phase and venous phase technique, but MR and endoscopic ultrasonography play a complementary role in a problem-solving situation. Small lesions, especially less than 2 centimeter functional tumors, can miss detection on CT if the arterial phase is not good, and these patients are the ones who one have to look for other technique. Also, incidentally detected lesions, the non-functioning tumors, which are less than 2 centimeter size, in older patients, if they don't show calcium or heterogeneity, those tend to be benign, and these can be managed conservatively. And with MRI, look at all the sequences. You have to look at each and every sequence that is available to make a more complete diagnosis. And diffusion is a nice problem solving for detecting non-hypervascular lesion. And imaging is also being applied to screen patients who are high risk for developing pancreatic neuroendocrine tumor. With that, I thank you all for your kind attention.
Muchas gracias, Dr. Sahani, por sus excelentes charlas. A continuación, veremos al Dr. Álvaro Huete, quien nos dará la charla